Respected chairpersons and friends, I'm supposed to talk about a case which is very peculiar, and nobody has drawn your attention to that part, that this patient has RCA graft occluded, some trickle flow is there in RCA, and the demonstrable ischemia is documented in circumflex territory. By circumflex territory documented ischemia, and still circumflex graft is working. So you have a non-obstructive territory which is ischemic, and you have a occluded graft, totally necrotic tissue in that area, and that is not producing any symptoms of angina. So when I'm talking about angina, angina is distant angina beyond RCA territory, and the graft to circumflex is working. So it's a peculiar scenario where INOCA or ANOCA is diagnosed, and I'm just going to tell you the details of all these things in a nutshell. You know, angina or myocardial infarction in non-obstructive coronary artery disease. By non-obstructive coronary artery disease, I mean to say less than 50% stenosis in that particular area. And what happens commonly when we go out to the relatives and say that you don't have any obstructive lesion, your coronaries are normal, it's a joyous reaction from family. So it's a good news to the family and patient. But what that no CABG is required, no stent is required, redo CABG in this case is not out of question. So only drugs, and choice is yours. The two choices you have already listened to, and those two choices are not my cup of tea. Why? That we'll discuss on further. But 40% of all coronaries have some non-obstructive lesion. Coronary angiogram taken in any center of the world, 30 to 40% are non-obstructive, and some 50% of women are presented with ANOCA or INOCA. So ANOCA, INOCA, is it a happy news? No, it's not a happy news, because risks are almost same. If I have coronary artery disease having triple vessel disease, and if I have minor lesions and ischemia in all three coronaries, I don't need stent, I don't need CABG, but at the same time my risk remains same. Tenfold increase in heart failure, preserved ejection fraction, stroke, microvascular dysfunction. INOCA multivessel disease is similar to that of patients with single vessel obstructive CAD and ischemic complications. So risk is not less. So it's not a happy news for the family. And there are three typical scenario. First and foremost is we all studied together princemental angina, epicardial coronary arteries, vasospastic coronary artery disease, and then there is a microvascular disease, small vessels producing angina. And you can have a vasospastic element over and above microvascular disease where nitric oxide is deficient. So these patients, management to date is no standard evidence based medicine, and that's why everybody will go on talking their own preferred molecule. But in nutshell, it's the underlying mechanism what we perceive. And in this scenario, I would say that this is a microvascular angina in circumflex territory which is causing problem. And there probably renolazine or there probably ivabradine has a little less role as compared to nicorandil. Dr. Soumya has already discussed about, documented clinical relevance or clinical identification of drug efficacy. But we have used aspirin, we have used clopidogrel, we have used sacubitril valsartan, but immediate clinical scenario may not be evident enough. So using a drug doesn't mean that all the time you have a clinical relevance, clinical monitoring. Of course, clinical monitoring is good, but that does not mean that it's an essential part of my therapy. The three types of angina mechanisms: first is microvascular angina, second is microvascular spasm, and third is epicardial vasospasm. All three are affected, all three are suppressed by only two kind of molecules. One is calcium channel blocker. Here nobody is talking about calcium channel blocker, so I am not touching that part. Apart from other molecules, only nicorandil stands. Nicorandil is the only drug which has impact on all three mechanisms of microvascular angina. So nicorandil coronary microvascular vasodilatory effect will be there, and that is balanced one. So first line therapy here will be verapamil, second line therapy will be nicorandil or longer acting nitrates producing vasodilatation, and if at all patient is having arrhythmia, then ICD. Is there a role of nicorandil in this case? Nicorandil mechanism and description I will just skip over because most of us know all these things. But then my point is to tell you the evidence, because out of all three molecules which are being discussed in this session, the first and foremost, nicorandil has the maximum volume of evidence. It has come in 2023 ACC/AHA guidelines. Of course, it is third line therapy along with renolazine, but the table of content which has been documented from that 2023 ACC/AHA guideline, the nicorandil is one step ahead of renolazine. There was in 2021 one classical international study group recommendation, and in that recommendation also, they discussed about nicorandil as the third option beyond beta blocker and calcium channel blockers. You have scientific publication right from 1981 to 2023, and in 2002 there was a mammoth trial of Iona. I'll discuss that later on. You have 6 editorial up till now. You have 27 meta-analysis, and all these are favoring nicorandil. Then why not to use nicorandil in my case? Nicorandil in 2023 was discussed as Delphi consensus statement. And these consensus statements are usually like, post-election exit poll. Sometimes they are right, sometimes they are not right. But these consensus statements do matter because it takes experts' opinion into it. And very important aspect was that this Delphi consensus dealt with number of questions. The first question was whether vasodilatory drugs are less utilized or not. Of course, yes. In such kind of scenario, people are not using long-acting nitrates. People are not using nicorandil. Then whether Inoca requires our nicorandil, yes, 91% of people will say yes. Beta blocker and nicorandil was the first choice for 54% of clinicians, and almost everybody agreed if you have LV dysfunction. In our case, LV dysfunction is present. So if you have LV dysfunction and chronic disease, chronic coronary artery diffuse disease, then 100% agreement in Delphi consensus statement that shows that nicorandil can be used. Nicorandil will work in microvascular dysfunction as well as vasospastic angina. Almost 50% of people agree to that. And of course, heart failure, preload, afterload reduction is also important phenomena. And what is the place in therapy for nicorandil injection? I would say that most of our cardiologists use it in cath lab either prior to or after that, and that has a special relation with sluggish flow, post sluggish flow or post no reflow phenomena, we would be tempted to use oral nicorandil in the follow-up, probably next 3 to 6 months. So these are the scenario where we use chronic slow flow. Of course, there are some legal ethnicity traits also. Small coronary artery disease, type 2 disease of diabetes, polyvascular disease. And in last year, Indian Heart Journal has also published one kind of exit poll scenario. And in that also I would jump into, because the time doesn't permit, but I would just jump into the consensus statement where nicorandil got 120 marks. Nicorandil with dual mechanism of action is effective in angina with normal coronary artery disease. There is crucial role here. Here one poster presentation from CSI conference, and that again shows that IV nicorandil therapy is to be used in TIMI grade 0 to TIMI grade 2 flow. And one more scientific study from China, 2022, that also showed very clear evidence. I would go to 2002 Iona study, 5,000 patients, mammoth study. And this 2002 study reminds me of Dr. Hiromu's lecture. He showed you Karthik Iron's photograph, but that doesn't mean that the older actors are worthless. Similarly, nicorandil, the mammoth documentation came in 2002. After that, we had renolazine. After that, we had ivabradine. So newer molecules are good, but that doesn't mean that older people are to be thrown out. And so nicorandil and Iona study documentation is perfectly all right for me. And then why not beta blocker step-up dose in this kind of case? That is also my question. Thank you very much.
Sir, over to you. Comments?
Hello. Sir, my question is, if patient is having chronic stable angina, normal angiogram without any slow flow, normal heart rate and normal heart function, then how to distinguish whether patient is having microvascular angina, endothelial dysfunction, and what should be the first line of anti-anginal drug?
In fact, microvascular testing is available on cath lab, and many a times we resort to, many a times we don't resort to. So the documentation of microvascular dysfunction or stress-induced ischemia with normal coronaries, they are to be documented, of course, before starting any good medication. But the cost therapy, cost of the new investigations hinders us for documenting them.
What should be the first line of anti-anginal drug?
I would still stick on to my recommendation of nicorandil, and then second line will be longer acting nitrates. I would say one important thing, renolazine 5% constipation rate, and every clinician has seen that constipation with renolazine. And you know, constipation is detrimental in acute coronary syndromes. Please. The same thing is ivabradine. Ivabradine can cause eye problems. Those are very detrimental and irreversible eye problems. So I should not break the other points, but my choice is nicorandil.
Your comment, sir.
Important to know the cause of angina, because there may be many other contributing factors to it, and then focus it on. There was one slide which was nicely shown whether it is obstructive disease or it is a slow flow, it is a endothelial dysfunction, or it is somewhere the problem in microvascular. So it's actually hard to say if the patient has normal angiogram, but if he still is having that typical anginal pain, maybe as sir has rightly said that you can get some challenge test, acetylcholine challenge and all are difficult to do, but I believe that can be done to look the microvascular dysfunction. And for this particular case scenario, I think this is a 76-year-old gentleman, so it's a quite geriatric population here. Rather than to add on, if we can try to just increase the metoprolol dose further, because there is still a chance to go up with that, and to avoid polypill more drugs with this old age can cause more problems. So I think that's the only thing. Thank you.
Dr. Somo, where atenolol's role today in the case shown to you?
All is forgotten most of the times.
That too by retrospective analysis,
Yes.
meta-analysis.
And the funny
The
part
two
is
bigger point is meta-analysis and retrospective analysis.
Any question, comment from the audience?
Job reading is also having a, I will share with you as a general physician, his off-label use is ongoing in ICUs where we have severe tachycardia and we are not able to add the beta blocker because of the worry of the hypotension.
Yeah,
So in
it's
that setting, we are using it for a shorter periods only.
a very nice drug.
Yes.
Doesn't have impact on blood pressure, but at the same time, if long-term use is there, I fear of a eye complication.
the problem I think with all these anti-anginal drugs is long term they have to be taken, it's costly, and what happens is with polypharmacy you choose so many drugs together, the cost increases tremendously and they end up not taking the basic drugs many a times. So they will stop some of the drugs, aaj aa lidi, pehle nahi lidi, aa karine. So it's always good to stick to the basics. If not, then try to revascularize if possible. That is the best thing.
Oh yes, but in this case, revascularization is not.
And then, if not, then they have to be counseled better rather than say that you take this drug if it doesn't happen. Let them have stable angina.
And the same thing is Nicorandil, Nicorandil has multiple formulations and temperature control, hygroscopic nature of the molecule. So you have to stick to one brand in the era of this
Jayesh bhai,
generic thing.
I have seen lot of atrial fibrillation in old patients who are taking ivabradine. In ICU
Can
patients,
precipitate, it can precipitate.
what books mention is about 6 to 8%, but in real sense, personally, this may be my, maybe
it's my
patients may be
observation
having.
also.
But a lot of times I also see patients of atrial fibrillation started ivabradine. At least that should not happen. That should not happen. A lot of patients get ivabradine for AF with fast VR. That should not happen. And